Hi, my name is Peter Acker. I'm a clinical instructor in the Department of Surgery and Emergency Medicine, and today we'll be discussing a case of anaphylaxis. We'll be discussing the approach to emergency patients, the initial interventions and workup, as well as the treatment and disposition for a patient with anaphylaxis. So our patient is a 33-year-old male who complains of lip swelling and abdominal cramping. At times, we have the luxury of time to evaluate, think, and act in a linear fashion. However, in emergency medicine, often these items happen in any order and often all at once. So with this patient, as we're meeting him, we're thinking about possible causes of his symptoms and we're immediately determining the most appropriate initial actions. So our evaluation begins with assessment of his general appearance and with his level of consciousness. We will then quickly move on to assessment of the A, B's, and C's, intervening wherever abnormalities are found. So for him, we notice that he's alert, but has flushed skin and is sitting upright. His airway, when we're assessing it, we ask him to state his name, and he's able to do so clearly, but we do see some swelling of his lower lip. When evaluating his breathing, we do note some mild respiratory distress, and after taking a listen to his lungs, some wheezing. On assessment of his circulatory system, we note he has weak distal pulses and his skin is cool to touch. So as you can see, there's a number of abnormalities that we find on our initial assessment: the general appearance, level of consciousness, and assessment of the ABCs. The second component to the initial assessment is assessing the vital signs. So it's essential for all patients to obtain a full set of vital signs, including the heart rate, respiratory rate, blood pressure, oxygen saturation, and the temperature. So for him, we note his heart rate is elevated at 120 beats per minute. His respiratory rate is also slightly elevated at 24 breaths per minute. His blood pressure, we note, is low for an adult at 85/60. Oxygen saturation on room air appears rather normal at 98%. And his temperature also fairly normal at 36.9. So as you can see, there are also some abnormalities on his vital signs. So we've completed our very precursory initial assessment, our evaluation, and now we begin thinking rapidly about the first decision we have to make for patients when we see them in the emergency department. And that is, are these patients sick or not sick? So this gentleman has a swollen lip. He appears pale, with a weak pulse and cool skin, and with the abnormalities on his vital signs that we saw on the last slide. So we've decided for this patient that he is, in fact, sick. So based on our ongoing assessment and what we've learned on our very quick evaluation, we determined the patient is sick, and now we have to decide what our immediate interventions are going to be. So here's a list of some of the most common initial immediate interventions for ill-appearing patients in the emergency department. For almost all of our patients, we start with an IV, placing them on supplemental oxygen, and applying cardiac and respiratory monitors. So for him, I think that's a very wise place to start. However, a caution is that for any patient in which we see swelling around the airway, you should begin preparing for airway management. So for this gentleman with lip swelling, we should already be thinking and planning for airway management. So we've completed our first round of evaluation, thinking, and acting. After meeting this gentleman very briefly, we already have a lot of information, and we've started our initial interventions. We now have to reassess the patient and reevaluate him for response to our initial interventions, and to gather a little bit more information to understand where his symptoms are coming from, and then what the next set of treatments and the ultimate disposition will be for this patient. So on our reevaluation, we want to gather a little bit more information. So we'll go through a very brief sample history, and we'll perform a focused physical exam, assessing the organ systems involved in his ongoing process. This information will lead us to formulate a differential diagnosis, and the items on that list will then prompt diagnostic testing to help us confirm or refute the items on the differential. So as you remember, the sample history involves asking a few brief questions for these ill patients, including symptoms, allergies, medications, past medical history, last meal, and the events surrounding their presentation. So for him, we understand that his symptoms involve lip swelling and abdominal cramping. In order to understand a little bit more about these symptoms, we can delve into the details using the OPQRSTU mnemonic. As you've learned in our prior lectures, those stand for onset, and for him, he describes the onset as about 20 minutes ago. The P stands for provocation, and for him, he describes this all happening just after being stung by a bee. The Q, quality, he describes a dull, crampy abdominal pain. R, radiation, he does not describe any radiation of the pain. S is for severity, and he describes it as moderate severity, or 6 out of 10. The T, or timing, he says was sudden onset, about 10 minutes after being stung by the bee. And U, or unifying symptoms, he describes a few other symptoms, including lightheadedness, anxiety, some itching to the skin, and then, as we noticed before, lip swelling. Following through the rest of our sample mnemonic, we ask him about his allergies, and he states he has a known allergy to bee stings. When asked about medication, he's on none. He has no past medical history. Last meal was about 2 hours ago, and the events surrounding his presentation include being at a park and being stung on the right arm by a bee. So these pieces of information give a background to frame your initial assessment, and then we'll move on to a focused physical exam. So for this patient, we want to look at the mucosa and the skin. The mucosa primarily because it involves the airway. We're looking for things like, can he speak? Is his tongue swollen? Are his lips swollen? And then also the skin, we want to assess for a rash. Is it flushed? And do we note piloerection, or the hair standing up? We also want to assess the cardiovascular system. We want to feel his pulses, assess the capillary refill. We want to note the color of his skin and any signs of mottling. And then when we feel his pulse, we want to feel the rate, the regularity, and the strength. We want to assess his respiratory system. We want to look for signs of upper respiratory problems, like feelings of throat tightness, difficulty breathing or speaking, voice changes, or stridor. And we also want to assess for signs of lower respiratory involvement, wheezing or cough, respiratory distress, retractions, or increased respiratory rate. We'll also want to assess his neurologic status and a brief neurologic exam, looking for any signs of neurologic dysfunction, asking for signs or symptoms of lightheadedness, tunnel vision, and his level of consciousness. And then lastly, as he mentioned some abdominal pain, we want to feel for presence or absence of reproducible tenderness, guarding, rebound, or distension. So when we assess our patient, looking at the mucosa and the dermatologic exam, when we inspect, we note that he does have the swollen lower lip that we noted during the ABC exam. His tongue appears normal. Currently, he's speaking clearly, but we note his skin is somewhat flushed, and he has a circumscribed rash on his arms and chest. Circumscribed meaning it has a very clear defining border. When we feel his skin, the rash is non-tender. It is slightly raised, and it blanches when we touch it. And that means when we apply pressure, the color leaves and then promptly comes back. But generally, his skin feels cool to touch. So we note a couple of abnormalities on this exam, and then we move on to the respiratory exam. Here, when we inspect, we see, as we noted previously, that the patient is in respiratory distress, exhibiting some retractions. When we listen, we hear wheezing throughout all of his lung fields. And when we palpate, we do not feel any chest tenderness. On the cardiovascular exam, we note that he's tachycardic, as we'd seen previously on the vitals. He has weak distal pulses. And then moving on to the GI exam, we actually find no tenderness on palpation, despite his complaint of abdominal pain. On the neuro exam, he mentions feeling lightheaded, but we do not find any other abnormalities. So we found some concerning findings on the respiratory exam, as well as the cardiovascular, the GI, and the neuro exam. In the cardiovascular exam, we're concerned that the tachycardia and weak distal pulses could be signs of decreased end organ perfusion or shock. The GI exam, it's interesting that despite the pain he described when we first spoke with him, we're not finding any tenderness on exam. And when we assess his neurologic status, although he is awake, he is describing lightheadedness, which might also represent poor cerebral perfusion. So now it's our job to try and put all the pieces together. What is causing this patient's symptoms? So a word of caution, although we don't know what's causing this patient's symptoms and we haven't done any testing, we have to treat presumptively for acutely life-threatening conditions. And this is a common theme in the emergency department. We're often working in a state of diagnostic uncertainty, but never delay treating potential life threats while waiting for confirmatory testing. So the summary of the first portion of this case is, it's our job to identify abnormal vital signs and respiratory distress very early. We want to prepare for early airway management in any patient with edema around the airway. And we also want to work during our evaluation to focus on identifying organ system involvement and unifying factors that will help lead us towards a diagnosis and the appropriate treatment.